the next immediate work that we embarked was to actually establish a international consortium with infectious disease specialists, oncologists, hematologists from all around the world to come up with a set of agreements. I wouldn't say they're guidelines, but consensus agreements to help guide institutions when they think about formulating their practices, relating to infection control, relating to continuing cancer care during this COVID-19 pandemic. And this was, there are few thoughts or sentiments from this work that has since been published in The Oncologist. Is, COVID-19 has revolutionized how we conduct research and how we connect as a global research community. When we wrote for the JAMA Oncology paper, this was written within 3 days, and once it was written, we decided to publish on MEDRICS to share the data openly. At the same time, concurrently, we submitted our paper to JAMA Oncology, and it was through the MEDRICS paper where the collaborators who made from UAE connected us with investigators from MD Anderson, and we came together and put together this consensus agreement within a week, where we were very specific in touching on some of the key considerations, again, in unique susceptible groups like patients who are undergoing surgery, pediatric patients, transplant patients, where we know that, with the, where this patient populations would be affected by COVID in a number of ways. The first, of course, would be the impact on their treatment itself. How with COVID-19 we see a huge the escalation of cancer care, from the diagnostic workflow all the way down to treatment. And we wanted to touch on how, perhaps innovative solutions can be thought of for this susceptible group of patients, like, for example, patients undergoing surgery, patients undergoing transplant. And then also talk about how potentially patients who are ongoing treatment, how they could not be affected by the COVID-19 crisis, such that the treatment could continue. So that was the, how the whole sort of group was put together. And here I must really sort of give credit to Humaid from the United Arab of Emirates, where he really put together this international consortium in a short time and get everyone to work together. And he was the main driving piece of the paper. But at the same time, it lent insights to perhaps how we should think about some of this unique population and how we could, come up with guidelines such that the care of these patients are not affected as much as possible. But it was also from that work that gave us some ideas on, what are some of the key questions that the community will need. Because at the same time, when we publish our guidelines, we also see and that continues to be the case, and a huge influx of lots and lots of guidelines papers in different forms. Most of them are some form of consensus agreements. Some of them are society statements. But they largely follow the same principles of tight infection control. How do we ensure continuity of care such that patients' care are not compromised? But what the global community really needs right now is it's evidence-based. It's evidence, really, data to help that on infection outcomes, on what are some of the interactions between anti-cancer treatment and outcomes on these patients. And so therefore, we then help to really modify this early guidelines better, such that it's actually data-driven, based on evidence, and as opposed to just physician discretion, biases, and sentiments of a few individuals or even groups. And so we decided to then look at examine again our own institution, the Zhongnan Hospital of Wuhan University, which is a tertiary cancer center in Wuhan, and look at some of the processes that were taken by our institution during this period and how that actually impacted on infection control outcomes and and the outcomes of cancer patients. I can't share too much now. Some of this work has been released on MedRix, and our research is currently under review. But I think I just want to take this opportunity to highlight and emphasize that such data is important, and it will help sort of really tighten things and modify some of these existing guidelines that are already out there. Just to share a few key points here. I think we found that clearly tight infection control is important in terms of mitigating patient-to-patient transmission, as well as patient and healthcare workers transmission. We also found that generally across the board, you will see a dialing back on patient numbers, and as much as we would like to continue cancer care and some form of stratification in terms of and prioritization of who needs care first has to be done, because we will see a substantial drop in patient numbers that are induced through a dial back of diagnostic services, both radiological as well as surgical. Surgical procedures we perform, the use of chemotherapy and other immunosuppressive agents, the concerns surrounding combination treatment. So all this will inevitably actually result in some form of hampering of cancer services. I think, and our data, as well as hopefully data from other centers, will help the global community think about these issues. And also, as you can again see, there are already emerging data with regards to the interaction between cancer treatment and outcomes. We again have a paper under review in this regard, but while waiting for our work, what you'll also see based on the AACR presentations yesterday, that there will be a aggregation of data sources from different nations. The French group presented, the TerraVote group, which is an effort by the international lung cancer community, as well as data from China, the US, will inform the community on the potential pitfalls of continuing with anti-cancer treatment, and whether the risk is uniform across all cancer treatment modalities or specifically to some modality like chemotherapy or transplant regimes or immunotherapy like immune checkpoint inhibitors, whether any of this treatment will aggravate the COVID-19 disease trajectory. So I think all this data will help, will provide evidence to guide practice, and this will also lead to the next wave of research in this field, where you will start seeing multi-centered as well as international collaboration. And there's a clear need and impetus for that, because despite the numbers that we treat at Zhongnan Hospital, and mind you, we had hundreds of patients who were COVID-19 positive. But yet, when you start looking, or when you start going deeper into some of the associations, like lung cancer and COVID-19 outcome, head and neck cancers and COVID-19 outcome, and we know that the modalities of treatment differ between cancer types, you will need to form robust conclusions. You will need large sample sizes, and the only way to derive these large sample sizes will be through aggregation of databases, meticulous prospective data collection, as well as early efforts to discuss about open data sharing, And I think that is important. I think the community recognizes that, and that will represent the next frontier of research in this front, where you will see large meta-analysis of different reports and different studies coming together. I think that and I think that will really help the community think about this problem in a robust scientific way, and also prepare the whole healthcare community a lot better in terms of dealing with a future pandemic.